Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clearnet serves as the digital partner for this event, and the focus of today's session is intravenous fluid therapy. Now, I would like to invite Dr. L. Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Penny and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions, including governing council member 2009 to 2012, president at 2011 to 2012, and secretary for 2006 to 2010 of the ISA Tamil Nadu State Branch. To proceed with the session, over to you, sir.
Thank you, Clearnet. At the outset, I request our President, Dr. Munian, to offer his presidential address.
Good evening, all. On behalf of ISA Puthukkottai City Branch, I welcome Honorable Moderator, esteemed colleagues, and fellow professionals. I am honored to address the critical role of intravenous fluid therapy in patient care. As we are the reputed anesthesiologists, we play a vital role in ensuring patient care and effective administration of intravenous fluids. We are conducting an online webinar every Wednesday. Today we are conducting 17th episode of second edition of IS Puthukkottai Bhudhan. What are the key principles of intravenous fluid therapy? One is fluid balance. By understanding the fluid balance is essential for optimal patient outcomes. And the second one is electrolyte management. Careful electrolyte management is critical to prevent complications. And third one is patient-centered care. It's nothing but tailoring fluid therapy to individual patient needs is critical. What are the best practices? Assessment on monitoring. Thorough essential monitoring of patients are essential for optimal fluid management. And fluid selections. Selecting the right fluid for the right patients is critical. And then third one is dose and rate. Careful consideration of dose and rate of fluid administrations are vitals. Clinical considerations. One is hypovolemia. Second one is electrolyte balance. Third one is fluid overload. Preventing fluid overload is crucial for our optimal patient outcomes. By following these principles and practices, we can provide optimal intravenous fluid therapy and improve patient outcomes. Today, we are gathering for online webinar, and our speakers are interested to share their experience with all of us. Let's listen to the online webinar. Over to you, sir. Thank you, sir.
Thank you, Mr. President. Now I request Dr. Kannan, our secretary, to offer his report.
Good evening, all. I am Dr. Kannan, Secretary, ISHD Branch. Successfully, we are conducting 17th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is intravenous fluid therapy. I welcome all our eminent speakers to the webinar. Last week, 7th May, we have conducted 16th webinar of Puthukkottai Bhudhan smoothly. Last week, our topic was anesthetic management of newborn. We have divided the topic into 8 subtopics. First one is anesthesiologist perspective in newborn airway, operative fluid therapy in newborn, anesthetic management of congenital diaphragmatic hernia. Our moderator was Dr. Mayank Masan. He is consultant in Vishesh Jupiter Hospital, Indu, Madhya Pradesh. First subtopic, anesthesiology perspective in newborn airway, was done by Dr. Aishwarya Pramod. She is resident, Care CHL Hospital, Indu, Madhya Pradesh. Second subtopic is perioperative fluid therapy in newborn. This topic was done by Dr. Venous, HOD, Care CHL Hospital, Madhya Pradesh. And third subtopic is anesthetic management of congenital diaphragmatic hernia. This topic was done by Dr. S. Mehta, consultant, Care CHL Hospital, Madhya Pradesh. Last webinar was attended by 870 delegates. Academic faculties, kindly encourage your postgraduates to attend our webinar continuously, which are very helpful in their exams. And one more thing, an important thing, we are going to conduct workshop and CME workshop on USG guided nerve blocks on June 14th and CME on June 15th at Puthukkottai MI Grand Hotel with 10 colorful topics with eminent national speakers. We are circulating the flyers for CME from now. Postgraduates and consultants kindly make a note on it. Thank you.
Thank you, Mr. Secretary. And now, as a thematic address, my duty is to introduce the faculty to the good group of audience. And before that, just because our secretary reported Dr. Mayank Masant was the moderator for the previous symposium, I want to inform today is Dr. Mayank Masant's birthday. So we wish him all the best and many happy returns of the day for Dr. Mayank Masant. So that sort of association we have with the fellow anesthesiologists. And as our secretary pointed out, this time we are going to organize a physical CME on June 14th and 15th. June 14th is going to be ultrasound guided nerve block workshop with 5 faculties dedicated for that. And the next day, Sunday, it is going to be a CME. And just because these faculty are from Kerala, I want to inform Dr. Swarna Kanil from Kochi. She is taking part in CME as well as workshop. And Dr. Ajay Kumar Hirshi from Trivandrum. He is going to talk on posterior fossa cranial surgery. And in addition, Dr. Chakrarao from Andhra Pradesh, Dr. Ramesh from Chennai, Dr. Narmata and Jenil Meklian from Tamil Nadu, Dr. Nandini from Pondicherry, Dr. Parsardi from Pondicherry. These people are with Dr. Kripagaran, our state president. He has moderated the symposium on spinal anesthesia. So he is going to talk about complications in spinal anesthesia. And the segmental spinal will be dealt with Suvarna Kanil. So I request the postgraduates and the young practitioners to exploit this opportunity on June 14th and 15th. And this week, we are happy to have the faculty from Kerala. Our youngest faculty, Dr. Vinduja Suresh is our youngest faculty. And she's the best student in anesthesiology because she is the best outgoing student in +2. She is the best outgoing student in MBBS also. She passed with the distinction. The idea of me telling is not to appreciate Dr. Vinduja. I want to say the intelligent people are taking up anesthesiology. So we should appreciate that point. So, and she is a classical singer. So what I want to say, people who are saying that they are not having enough time, they never succeed. People who are succeeding, they exploit all the time available with them. So Dr. Vinduja, the youngster, is one among that. And not only she is a singer, she is a violinist. See, from the very beginning, I also trained to learn music, not possible. And even after retirement, I have purchased one guitar because it costed only 8,500 rupees, which I had at that time. But I went only for 15 days class. So not possible because my fingers were paining. I am such a lazy person, and nice to see Dr. Vinduja is playing with violin, and she is a topper in class 12. As I said, she is the topper. And MBBS also with distinction and secured so many prizes in quiz competition actually. She has attended various CMEs, but now he's a faculty in CME. So the appreciation goes to Dr. Shamsad Madam. She has picked up the best. She has picked up the best. That is the success of Puthukkottai Bhudhan. The best introductory point I can offer for Dr. Vinduja is Dr. Vinduja is waiting for a intelligent and matching spouse. So that is the most important point. Nearly 900 people will be visiting this, and such an intelligent girl from Perinthalmanna is waiting for that opportunity to strike. I don't know what is going to happen in future. So I wish her all the very best. And it will be followed by Dr. Anjali Rajan. Dr. Anjali Rajan is a AP. She did her MBBS from Amala Institute. I think Amala Institute, Thrissur, where madam also worked as a HOD or a Shamsad madam, and she did her MD from KEM Hospital, that is Mumbai. So she has done her SRship in Mumbai and now working as an assistant professor in Perinthalmanna. And the fun is she is also a good musician and a singer, and she is interested in painting. So I don't know whether all lady doctors are interested in music, dance, and painting. But music and dance, everyone. Even we have Dr. Revati B. Nair from Kerala. She is also a singer, a dancer. So I think Kerala is producing many people interested in that. And just because these people have become anesthesiologists, some next level generation is getting name in the movies as well as in music and dance. In fact, we have good dancers in the anesthesiology group, so we should appreciate that. And Dr. Anjali will be followed by Dr. Asitha. Asitha has done MBBS from Perinthalmanna, MES Medical College, where she is working as a assistant professor. So same area where she worked, and she did her DA from Calicut, and now she is the AP. And naturally, as a lady doctor from Kerala, she is also a good singer and a dancer. I don't know if I contest a competition for all the three, who will succeed, I don't know. But hopefully the best outgoing will be Dr. Vinduja because of her caliber to dance and sing. And see, the entire team is picked up by none other than Dr. Shamsad Madam. See, Dr. Shamsad Madam, I need not introduce her formally because I know her repeatedly. First of all, I want to say more than a teacher, she's a good entertainer. So the art and music will be loved by her. So she encourages everyone. She encourages everyone as if they are a very top people. And naturally, we will feel that we are on top. That is the reason why she has picked up all the three, because every time she used to say, "Sir, you are talking very well." That means she appreciates. So that means she encourages us to talk nicely, and she has picked up all the three. So Madam was topmost person not only in Thrissur, in the entire country, but Madam's entire official career was in Thrissur only. So Madam was working in Thrissur as AP and a professor, HOD, and she has even become the medical superintendent of Thrissur Medical College. So slowly, step by step, she is improving. The same way, she was the city branch secretary of Thrissur in ISA, followed by President ISA Thrissur City Branch. And again, she was the secretary of the state branch. She was the president of the Kerala state chapter. And when Madam was the president, I had the opportunity to visit that is Kochi. Kochi, Madam has even conducted that ISA South Zone assembly there. So even after doing all these things, whenever she becomes an examiner, she is an examiner for DA, MD, and Depend B candidates. She used to be very liberal with them. And the best part of Madam is all the three may not be knowing. She is having 34 years of teaching experience, but always looks like 34 years old. See, because that is the charm of Madam. She attracts everyone. And I know her spouse also. That means the ISA has given us the opportunity to interact with the people. So he's Ayurvedic physician, if I am right. So he also used to accompany. So don't think that there is always a woman behind a successful man. There may be some men behind a successful woman. So Madam is a classical example for that. And I hope a few faculty and a few postgraduates will be attending the CME and the workshop in Puthukkottai. And I hand over the scientific session to Madam. Please take over.
Okay, thank you for sir for the nice words that you have said about all of us. Okay, as in everywhere, all the time when I meet you, you are always appreciating us. Okay, thank you very much, sir. And also for this time also, first of all, I take this opportunity to thank Dr. Meenakshi Sundaram, sir, and his team in Puthukkottai Bhudhan for giving us a chance to participate in this mega event, mega CME or mega academic event. I think so. Because sir is aiming at very high levels of from 1,000 to 1,500. Okay. The aim of SIR is also really appreciating. That is to bring out the youngsters as academicians by giving chances like this. Okay. Now I coming to my topic. That is today's topic is IV fluid therapies. As anesthesiologists, we are using IV fluids to all the patients who are coming to us for anesthesia from the preoperative period till the postoperative period, and once they becomes coming out of the effects of anesthesia as well as the effect of the surgery. So my team for today's presentation includes, as Sir introduced, Dr. Vinduja. She will be presenting on physiology of the fluids, and followed by Dr. Anjali Rajan. She will be saying about the different types of fluids as well as its clinical significance. And Dr. Asitha will present regarding the perioperative management of the fluids. I hope it is heard to all of you, isn't it? Okay, sir. Am I audible?
Audible, madam.
Audible. Okay.
Oh, yes.
So now we can start with the program. That is over to Dr. Vinduja. Okay, sir.
Good evening to one and all. So my topic for today's presentation is physiology of fluids. So understanding the fluid physiology is fundamental in comprehending how the body adapts to stress, illness, and treatment interventions. So moving on to physiology of fluids in detail. Introduction. Water constitutes approximately 60% of the total body weight in an average adult, though this percentage can vary based on age, sex, and body composition. So in females, the total body water is 50% of total body weight. This is mainly due to increased proportion of adipose tissues. These fluids are further distributed between the intracellular and extracellular compartments, each with distinct compositions and functions. So proper regulation of fluid volume and composition is essential for cellular activities, nutrient transport, and waste removal. As already mentioned, the body fluid compartments are broadly distributed into intracellular fluid, which is the fluid inside the cells, and the extracellular fluid, which is the fluid outside the cells. So there is another entity known as transcellular fluid. So what are transcellular fluid? These are the fluids that are outside of normal compartments. It is approximately 1 to 2 liters of fluid, and it is usually seen in cerebrospinal fluids, digestive juices, and mucus, etc. So this table depicts the age-related variation in total body water and extracellular fluid as percentage of body weight. As it is clearly seen, neonates have a higher total body water compared to that of adults. Fluid distribution relative to body weight. As already mentioned, fluids are broadly categorized into the intracellular fluid and extracellular fluids. The intracellular fluid constitutes 40% of the total body weight, or 55 to 75% of total body water. This usually resides in the cytoplasm within the cells. It remains relatively stable and resists rapid changes, which is crucial as it hosts various biochemical processes. Maintaining osmotic balance here is vital to ensure cellular function and integrity. Next is the extracellular fluid. It constitutes 20% of total body weight, or 25 to 45% of total body water. It is again divided into an interstitial compartment, which roughly comprises of 15%, and a circulating compartment about 5%. This circulating compartment is further divided on a 1:3 basis into intravascular fluid, which is the plasma, and extravascular fluid. It plays an important role in nutrient transport, waste removal, and itself acts as an extracellular reservoir for fluid during clinical interventions. So this figure depicts the distribution of total body water between different fluid compartments.
The intracellular fluid is 55%, extracellular is 45%. The extracellular is further divided into a functional ECF and a sequestered ECF. The functional ECF is constituted by the interstitial fluid, intravascular fluid, plasma, and subglycocalyceal layer. The sequestered compartment comprises of the bone and dense connective tissue and the transcellular fluid. Moving on to chemical composition of fluid compartments. From the table, it is clear that the intracellular compartment is rich in potassium, magnesium, phosphorus, and protein, whereas the extracellular compartment is rich in sodium, chloride, and bicarbonate ions. Moving on to the basics. So, what is diffusion? Diffusion is a process by which the solute particle fills the available solvent volume by movement from areas of high to lower concentration. What is effective circulating volume? It is that part of the extracellular fluid that is in the vascular space and effectively perfusing tissues. Solute is defined as a substance that is dissolved in solution. So, the concentration of a solution is expressed as the total number of solute particles per kilogram of water. Next is osmolality. It is a solute concentration of a fluid. It is usually expressed as milliosmoles per kilogram of water. Serum or plasma osmolality measures the different solutes in plasma. The normal value ranges between 275 to 290 milliosmoles per kilogram, and it is usually derived from the measured sodium, urea, and glucose concentrations. So the serum osmolality in milliosmoles per kilogram is equal to 2 into serum sodium plus serum glucose in milligram per deciliter by 18 plus blood urea nitrogen in milligram per deciliter divided by 2.8. So why is sodium value multiplied by 2? Sodium is most commonly seen in the extracellular compartment, and it is almost always accompanied by the negatively charged ions, namely chloride and bicarbonate in equal proportions. On dividing serum glucose by 18, we can derive the value in millimoles per liter. And similarly, by dividing blood urea nitrogen by 2.8, we get the same value in millimoles per liter. Blood urea nitrogen can be derived from urea. So BUN is equal to urea in milligrams per deciliter divided by 2.14. Next is tonicity, which is also known as the effective osmolality. It is the sum of the concentration of solutes which have the capacity to exert an osmotic force across a membrane. So tonicity is the relative concentration of solutes dissolved in the solution, which determines the direction and extent of diffusion. Based on tonicity, fluids can be broadly categorized into hypertonic, isotonic, and hypotonic solutions. So hypertonic solutions are those with higher concentration of solutes. Isotonic, the solutions being compared have equal concentration of solutes. And hypotonic, the solution with lower concentration of solutes. Next is osmotic pressure, which is also known as hydrostatic or water stopping pressure. It is the minimum pressure that must be applied to a solution to hold the flow of solvent molecules through a semi-permeable membrane. What is osmolar gap? Osmolar gap is defined as the difference between measured and calculated osmolality of serum. The normal value is between 10 to 15 milliosmoles per kilogram. So osmolar gap, or when the osmolar gap is more than 50 milliosmoles per liter, it is usually seen in cases where there is alcohol content in the body, especially with ethanol, methanol, and ethylene glycol. It is also seen in hypertriglyceridemia and hypergamma globulinemia. Next is fluid movement mechanisms. What is passive diffusion? Passive diffusion is when the fluid traverses a semi-permeable membrane driven by concentration gradients of osmotically active solutes. Next is osmolarity, which is defined as the particle number per liter. The physiological plasma osmolarity averages to approximately 286 milliosmoles per liter. Fluid shifts towards hyperosmotic compartments and away from the hypoosmotic ones, which is crucial for maintaining cellular and plasma volume. Next is active ionic transport, where the cell membrane ionic pumps expends energy in the form of ATP to create and sustain concentration gradients, which is critical for osmotic balance. Next is osmotically active components. The examples include ionic species, proteins, with notably albumin, and glucose to establish a solute gradient. So this itself pulls the water into compartments, maintaining fluid homeostasis across the membranes. Next is hydrostatic force. The hydrostatic pressure provides a push on the fluids, forcing the movement out of the compartments, particularly from plasma into interstitial spaces. Next is capillary filtration. This mechanism underlies filtration across capillaries, balancing volume distribution in extracellular compartments and impacting fluid therapy strategies. Next is the Starling's principle. So membranes which are non-permeable to an ion produce a gradient relatively of higher osmolarity, which creates a pull of water into the fluid compartments. In addition, fluid movement within the body depends on created and maintained hydrostatic pressure, which is the push factor on fluid movement, where increased pressure forces fluid out of the space. So according to the Starling's principle, movement of fluid across a membrane mainly depends upon two forces, which is the hydrostatic pressure, which is acting at the arteriolar end of the capillaries, and the oncotic pressure, which primarily acts at the venular end of the capillaries. So the Starling's equation is as follows. The amount of fluid flow per minute, or the net fluid movement across a capillary membrane, is equal to the capillary filtration coefficient multiplied by the capillary hydrostatic pressure minus the interstitial hydrostatic pressure minus osmotic reflection coefficient into plasma oncotic pressure minus interstitial oncotic pressure. So the capillary filtration coefficient reflects the capillary permeability. It is usually affected by the shear stress and endothelial dysfunction. The capillary hydrostatic pressure pushes the fluid outwards. It is 32 millimeters of mercury at the arteriolar end of the capillary and 15 millimeters of mercury at the venular end. The capillary hydrostatic pressure is usually affected by gravity, mainly posture, and blood pressure. The interstitial hydrostatic pressure is usually negative, ranging from -5 to 0 millimeters of mercury in most of the tissues, except in encapsulated organs. It is affected by modifications in lymphatic drainage, as seen while applying tourniquet or during immobility. Next is the osmotic reflection coefficient, which indicates the membrane selectivity. It indicates protein permeability or osmotic force between the compartments. When it is more than 1, it indicates that the membrane is impermeable, and when it is equal to 0, it indicates that the membrane is highly permeable. So the plasma oncotic pressure is 25 millimeters of mercury, and the interstitial oncotic pressure is 5 millimeters of mercury. Now, these are the two graphs which depicts the classical model of Starling's principle and the revised model of Starling's principle. So according to this classical model, as stated earlier, the fluid traverses across a membrane or into the interstitial space, mainly due to difference in hydrostatic and oncotic pressure. As it is clearly seen, at the post-arteriolar capillary segments, the hydrostatic pressure is greater than oncotic pressure, hence it favors fluid movement into the interstitial space. At the post-capillary venules, the oncotic pressure is greater than the hydrostatic pressure, favoring movement of water from the interstitial space into the venules. But according to the revised model of Starling's principle, the hydrostatic pressure remains more than that of the oncotic pressure, even at the precapillary arterioles and postcapillary venules. It indicates that the fluid is not reabsorbed back into the venules, rather than it is usually collected by the lymph. So here comes the importance of the endothelial glycocalyx layer. So it is a highly fragile layer that forms an integral part of the vascular barrier. It plays an essential role in maintaining the normal fluid homeostasis of the body. It influences the fluid flux across endothelial cells and regulates vascular tone and permeability. The revised Starling's principle highlights the importance of the endothelial glycocalyx and the subendothelial glycocalyx space in governing transcapillary fluid exchange. This model suggests that filtration occurs across the glycocalyx, and the lymphatics plays a major role in returning the fluid into circulation, unlike the original Starling's model, which proposed venous reabsorption. So the endothelial glycocalyx layer is a gel-like matrix that coats the luminal surface of the vascular endothelium. Its thickness varies from 200 nanometers to 2 micrometers. Now, what are the components of endothelial glycocalyx? It mainly consists of glycoproteins, negatively charged glycose aminoglycans, proteoglycans, and associated plasma proteins, including albumin. The proteoglycans are bound protein of the syndican or glypican families, and it itself acts as a core membrane to which the negatively charged glycosaminoglycans are attached. Albumin binds tightly to the glycocalyx, and it helps in reducing the hydraulic conductivity of the membrane. Moving on to the functions of the endothelial glycocalyx. It helps in maintenance of the vascular permeability barrier. It helps in mediation of shear stress dependent nitric oxide production. It helps in retention of vascular protective enzymes, example superoxide dismutase. It helps in retention of coagulation inhibition factors, example antithrombin, protein C system, and tissue factor pathway inhibitors. It helps in modulation of inflammatory response by preventing leukocyte adhesion and binding various ligands. Examples include chemokines, cytokines, and growth factors. So the delicate endothelial glycocalyx can be damaged by various pathophysiological conditions and interventions. Some of them are mentioned here. These include trauma, sepsis, diabetes, electrolyte imbalance, surgery, inflammation, ischemia reperfusion injury, and hypervolemia. Improper or overzealous rapid administration of IV fluids, be it crystalloids or colloids, can also damage the endothelial glycocalyx. The rapid administration can initiate the glycocalyx layer shedding, potentially causing diffuse coagulopathy. Hypervolemia increases the release of atrial natriuretic peptide, which acts as a trigger for the endothelial glycocalyx destruction. So, what is the clinical significance of endothelial glycocalyx? Any damage to the endothelial glycocalyx can lead to increased vascular permeability. It can also cause capillary leakage. So these two mechanisms further leads to development of generalized edema. Not only that, damage to the endothelial glycocalyx can cause pro-inflammatory and hypercoagulable state as well as compromised vascular reactivity. So damage to the endothelial glycocalyx layer acts as a primary pathophysiological mechanism in development of heart failure, nephrotic syndrome, liver cirrhosis, sepsis, acute lung injury, and ARDS. So on summarizing, body fluids are vital for homeostasis and are distributed into the intracellular fluid and extracellular fluid compartments. Effective circulating volume, osmolality, tonicity, and osmotic pressure regulates fluid balance across the compartments. Fluid movement occurs via passive diffusion, active transport, and hydrostatic forces, which is again guided by the Starling's principle. The endothelial glycocalyx layer is crucial for vascular barrier integrity as well as for maintaining normal fluid balance. These are my references. Thank you.
Thank you, Vinduja, for the excellent presentation. Okay, sir.
With your permission, because I have missed some few faculties from Kerala. Actually, Dr. Anaga is from Kochi, Kerala. Then Dr. Vijish Venugopal from Calicut. Then Dr. Suvarna Kanil from Calicut. Then our person from Trichy. See, he is a moderator for PG panel discussion with the examiners. The topic is how to impress the examiner. So that is the topic which is going to be moderated by Dr. Ganesan, and we have 4 faculties actually from Kerala: Dr. Anaga, Dr. Vijish Venugopal, Dr. Swarna Kanil, and Rishi from Trivandrum. Thank you, madam. Over to you.
Okay, sir. Shall we move on to the next topic, sir?
Yes, that is
Doc-
your domain.
Yeah, okay. Dr. Anjali Rajan will be presenting about the different types of fluids as well as their clinical significance. Now, we can hear about some.
Thank you, ma'am.
Yeah.
So, am I audible? And is my presentation visible to everyone? Am I audible?
Yes,
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 ma'am.
you need
Yes, you are
Okay. Okay. Okay.
yeah, audible. Okay.
So, good evening, everyone. Moving on to the topic, clinical significance of various intravenous fluids. So, this session provides a concise overview of the current understanding of the safety and efficacy of various intravenous fluids that is available for perioperative purpose. So, why is it very important for us to know about intravenous fluids? Because, as we all know, it is crucial for the safe and effective administration. And incorrect fluid management can exacerbate patient outcomes and prolong the hospital stays. So before prescribing any fluid, there are certain questions that we need to know. So we should know the clinical status of the patient, what is the underlying cause of the fluid deficit, what are the coexisting medical conditions, and regarding the fluid, we should know when to start the fluid, when it should be stopped, which fluid we have to administer, at what concentration, at what rate, and how long we have to administer. So after answering all these questions, then we have to decide which is the best fluid for that particular patient in that clinical condition. So what is the purpose of giving intravenous fluid? So if given a choice, oral route is the most preferred route. But in certain clinical scenarios, like as in acute hypovolemic shock, intravenous fluid is always life-saving. Other indications are it is used as a maintenance fluid in the perioperative period to restore and replace the fluid losses. It is used as a vehicle for various intravenous medications to correct severe hypoglycemia and to correct electrolytes and acid-base imbalances. In case of metabolic acidosis, fluids containing bicarbonate precursors, that is lactate and acetate, are preferred. The most common example is Ringer lactate. Whereas in case of metabolic alkalosis, isolite G stands out as the single most fluid that can correct the alkalosis. This is because of the presence of ammonium chloride that is present in isolite G, which gets converted to urea and H plus ions in liver. The advantage of giving an intravenous fluid is because we are introducing the fluid directly into the intravascular compartment, the response is very rapid. But it is feasible only in a hospital setup under supervision. So, intravenous fluids are broadly classified as whole blood and products and non-blood IV fluid components. Today, we are going to focus only on the non-blood IV fluid components. They are classified again based on the physical properties into crystalloids and colloids. And crystalloids can be isotonic, hypotonic, or hypertonic with respect to plasma. As per clinical usage, crystalloids can be used as maintenance fluid, replacement fluid, or resuscitation fluid. And colloids, they are classified as monodisperse or polydisperse based on the molecule chain length. So if the molecule chain length is uniform, that is monodisperse, the common example is albumin. And if the molecule chain length is different, it is polydisperse colloid. The common examples are dextrans and hydroxyethyl starch and gelatins. So what is the basic difference between a crystalloid and colloid? So crystalloids are small molecules in water, hence they easily cross a semi-permeable membrane. Because of this, the duration of a crystalloid within the intravascular compartment is very short, that is 20 to 30 minutes. And it do not exert any oncotic pressure, hence in case of volume loss, it has to be replaced in higher quantity. That is, for 1 ml fluid loss, we have to replace with 1.5 ml of crystalloid. The earlier belief was to replace with 3 ml of crystalloid. Whereas colloids are larger organic molecules in a carrier solution. They do not cross the plasma membrane. Hence, the duration of stay within the intravascular compartment is long, that is 3 to 6 hours. They also exert an osmotic pressure and the volume replacement ratio comes to around 1:1. Crystalloids can be classified as balanced and unbalanced. So balanced crystalloids contain electrolyte concentration similar to that of plasma. Common examples are Ringer lactate, Ringer's acetate, and plasmalate 148. Example for unbalanced crystalloid is normal saline. Example for balanced colloids are tetraspan, hextant, volulite, and gelaspan.
And examples for unbalanced colloids are hetastarch, pentastarch, Bollivan, human albumin 5%, and gelofuscin. So even though the electrolyte concentrations are similar to plasma in a balanced solution, they always contain higher amount of potassium than unbalanced solution. So this is a table showing the composition of common IV fluid solution. So it is very important for us to know the composition in order to decide the fluid of choice for that particular clinical situation. The normal plasma osmolarity comes to around 275 to 290 milliosmoles per liter. So solutions which contain electrolyte concentration similar to that of plasma with an osmolarity 270 to 310 milliosmoles per liter are isotonic. They are more physiological, hence the cells immersed in the solution do not lose or gain water. Examples are normal saline and ringer lactate, and they are more commonly used for maintenance and replacement. Whereas solutions which contain concentration lesser than that of plasma with an osmolarity less than 270 milliosmoles per liter are hypotonic. Here the cells immersed in the solution tends to swell. They are needed for cell hydration or if the plasma is too much concentrated. Examples are half normal saline and 5% dextrose. 5% dextrose is isotonic, nearly isotonic outside the body with an osmolarity of 252 milliosmoles per liter. But after infusion, dextrose gets metabolized very fast and what is left is only free water. Hence, solution becomes hypotonic after infusion. They are mainly used in conditions like hypernatremia. Whereas the solutions which has concentration more than that of plasma are hypertonic with an osmolarity more than 310 milliosmoles per liter. Here the cells immersed in solution tends to shrink. Common examples are 3% saline and 5% saline, and they are used in cases of hyponatremia and cerebral edema. They are needed in cases of used in cases of cellular edema. So what is the clinical significance of knowing the tonicity of intravenous fluids? So when an isotonic solution is infused, it tends to remain within the extracellular compartment. That is equally distributed between the interstitial space and the intravascular space. Hence, isotonic fluids cause more effective expansion of the intravascular fluid compartment than hypotonic solution. But when a hypotonic solution is infused, it quickly shifts from the intravascular compartment to the intracellular compartment. This can cause a decrease in the intravascular volume, causing worsening of hypovolemia, and these have to be avoided in patients at risk of raised intracranial pressure. This is because of the risk of developing cerebral edema. When a hypertonic solution is infused into the intravascular compartment, they tends to draw water from the intracellular compartment to the intravascular compartment. This can cause volume overload, hence they have to be avoided in cardiac and renal patients. So based on the indication, again, fluids are classified as maintenance fluid, replacement fluid, and resuscitation fluid. So maintenance fluid, they are mainly used during the perioperative period in hemodynamically stable patients. It provides the daily requirements of electrolytes, dextrose, and water. Whereas replacement fluid is used to correct an existing or developing deficit that cannot be compensated by oral intake alone. And resuscitation fluid is used in case of acute hypovolemia. So any fluid has to be explained in terms of physical property, concentration, and indication. We should know whether the fluid is a crystalloid or colloid. Is it isotonic, hypotonic, or hypertonic with respect to plasma? Or what is the indication? Is it used for maintenance or as replacement or for resuscitation? So starting with the grandfather of IV fluid, that is 0.9% normal saline. It is an isotonic crystalloid that is used commonly as a replacement fluid. It has equal concentrations of sodium and chloride, that is 154 milliequivalents per liter. It is an ECF replacement fluid. That means after infusing 1 liter of sodium chloride into the intravascular compartment, 25% or 250 ml remains within the intravascular space and rest enters the interstitial space. The indications are commonly in resuscitation, in replacement, and for dilution of various drugs, and in case of hypochloremic metabolic alkalosis due to vomiting or nasogastric suctioning. It is contraindicated in conditions which can retain sodium, like in congestive cardiac failure, pulmonary edema, and renal impairment. Sodium chloride can be infused with packed RBCs because they are devoid of calcium and are isotonic with blood. But large volume resuscitation with sodium chloride, that is 1.5 to 2 liter per day, can cause a condition called hyperchloremic metabolic acidosis. This is because of the supraphysiological concentration of chloride, that is 154 milliequivalents per liter, that is present in normal saline. Whereas our normal plasma chloride concentration is only 98 to 108 milliosmoles per liter. This hyperchloremia can cause acute kidney injury because of increased renal vasoconstriction, reduced renal perfusion, and reduced glomerular filtration. And hyperchloremic metabolic acidosis can cause a transcellular shift of potassium from the intracellular compartment to the intravascular compartment. So actually, only 98% of potassium is present in the intracellular compartment, and only 2% of potassium is available in the extracellular compartment. So this slightest transcellular shift of potassium from the intracellular compartment to the extracellular compartment can cause clinically relevant hyperkalemia. Also, infusion of more than 1 liter of normal saline per day can increase the sodium levels by 0.6 millimoles per liter. And large volume infusion can cause iatrogenic fluid overload. One important question is normal saline truly normal? So the answer is no, because the sodium and chloride concentrations in normal saline is actually higher than the normal serum plasma concentration, that is 154 milliequivalents per liter. The pH of normal saline is 5, whereas our normal plasma pH is 7.4. And the osmolarity of normal saline comes to around 308 milliosmoles per liter, whereas the normal plasma osmolarity is 275 to 290 milliosmoles per liter. Hence, the normal saline is truly not normal. So because of all these disadvantages, that sets in the need of IV balanced salt solution. So these are crystalloids which with composition and electrolytes similar to that of ECF. They have chloride content equal to or less than 110 milliequivalents per liter. An ideal balanced salt solution should have strong ion difference similar to that of plasma strong ion difference. So strong ion difference, it is a difference between strong cations and strong anions in the body in a solution or plasma. The normal plasma strong ion difference comes to around 40 to 42 milliequivalents per liter. And SID value is directly proportional to pH. So any solution with an SID value less than 40 is acidic and more than 42 milliequivalents per liter is alkaline. So we can choose the right fluid for that particular condition based on the whether the condition is acidotic or alkalotic. And balanced salt solution also contain added buffers like lactate, acetate, and gluconate that gets converted to bicarbonate in vivo. Hence, they have minimal effect on ECF homeostasis, acid-base equilibrium, and electrolyte concentrations. So coming to the first balanced salt solution, which is used in day-to-day life, that is Ringer's lactate. So it is an isotonic balanced crystalloid which is used for maintenance or replacement, and it has composition similar to that of normal plasma. So Ringer's lactate effectively expands ECF like a normal saline, and it is a physiological fluid. So because of this biological composition, larger infusions of Ringer lactate will not cause any electrolyte imbalance. And it provides bicarbonate, hence it is valuable in the treatment of metabolic acidosis. So one important question is whether Ringer lactate, larger volume infusion of Ringer lactate causes lactic acidosis. Answer is this is because lactic acid contains the positively charged cation H plus ion that binds with lactate to form an acidic substance. Whereas the sodium lactate, which is present in the Ringer lactate, contains the positively charged cation sodium that binds with lactate to become an alkaline substance. So actually speaking, the pH of both substances are in opposite direction. Hence, Ringer lactate will not cause lactic acidosis. Then the effect on chloride level. So unlike normal saline, Ringer lactate will not cause hyperchloremic metabolic acidosis because the chloride concentration is only 109 milliequivalents per liter, which is almost similar to that of plasma. Another important question is again is Ringer lactate, whether Ringer lactate can be given in patients with hyperkalemia. The answer is yes. This is because of the alkalinizing effect of Ringer lactate, which prevents the potassium shift from intracellular fluid to extracellular fluid compartment. Also, addition of just 4 milliequivalents of potassium into the large ECF compartment is negligible. So, if given a choice between Ringer lactate and normal saline in patients with hyperkalemia, it is always Ringer lactate because larger infusions of hyperkalemia causes hyperchloremic metabolic acidosis, which can cause the transcellular shift of potassium and can worsen the hyperkalemia. So, always choose Ringer lactate over normal saline. I think that is clear. So indications, current guidelines suggest the use of Ringer lactate in diabetic ketoacidosis, again because of the same reason of presence of bicarbonate precursor and nil development of metabolic acidosis. It is contraindicated in severe liver dysfunction. This is because the lactate metabolism can get affected. Unlike normal saline, ringer lactate cannot be administered with stored blood. This is because the citrate that is present in the stored blood and calcium present in ringer lactate can cause clotting of the blood in the infusion tubing. So these are some studies that has compared between the efficacies of balanced and unbalanced crystalloids. So some of the named trials like the SALT ED trials in 2018, the SMART trial in 2019, they concluded that balanced salt solutions are always superior to normal saline. But later, some of the trials like the split randomized trial in 2015, the SALT randomized trial in 2017, the BASICS trial in 2021, and the PLUS study in 2022, they found that there is no difference between the efficacy of normal saline and balanced salt solution. But what we have to understand is there is not a single study that has demonstrated the superiority of normal saline over the balanced salt solution. Hence, the conclusion is that balanced crystalloids are always safer than normal saline, but not always superior. Coming to the next balanced crystalloid, that is Ringer's acetate. Here we have the bicarbonate precursor acetate. So one advantage is that acetate gets metabolized in whole body cells, not only in liver. Hence, Ringer's acetate can be used in conditions where Ringer lactate is contraindicated, as in case of severe liver dysfunction. And it has a better buffering action because the bicarbonate formation is faster, and it does not affect the serum lactate levels, unlike Ringer lactate. Next balanced crystalloid is plasmalate 148, which is isotonic. It is similar to Ringer lactate solution with the following differences. Here the sodium content is 140, which is similar to the plasma value, and it has acetate and gluconate as bicarbonate precursor, and it has magnesium instead of calcium. The osmolarity comes to around 290 milliosmoles per liter, and this 148 number is because of the sum of cation concentrations of sodium, potassium, and magnesium. It can be, so unlike Ringer lactate, it can be administered with blood because it has magnesium instead of calcium, and it is the preferred balanced salt solution in liver transplantation than Ringer lactate. This is because after liver resection, serum lactate levels plays as an important prognostic factor. So that serum lactate levels can get altered with over use of Ringer lactate. Hence, plasmalate 148 can be used in such scenarios. So acetate, the potential problem is acetate can produce a dose-dependent decrease in cardiac contractility and blood pressure. Here are some studies which compare different balanced salt solution, that is Ringer's lactate versus acetate buffered solutions. So studies like Weinberg et al., Rawat et al. In 2018 and 20, they concluded that both Ringer lactate and other acetate buffered solutions are equally effective. But later, some of the studies from 2021 to 2023 found that acetate buffered solutions are superior to Ringer lactate. But what we have to realize is because of this small patient cohorts used in this study and the number of studies were limited, there is no strong recommendation to use acetate buffered solutions over Ringer lactate. Hence, the conclusion is, among the balanced salt solution, Ringer lactate is the most preferred fluid as it is inexpensive, readily available, and more physiological. In contrast, acetate buffered solutions, due to its compositional advantage, can be used in scenarios where Ringer lactate is contraindicated, that is in case of severe liver dysfunction. Next crystalloid is half normal saline. It is an hypotonic crystalloid. It contains half the sodium, that is 77 milliequivalents when compared to 0.9% normal saline. It is used in correction of hypernatremia. Since the correction is very gentle, it avoids the development of cerebral edema, and it can be also used in diabetic ketoacidosis after the initial 0.9% normal saline treatment. Next is 5% dextrose, which is isotonic outside the body, which becomes hypotonic after infusion. It is used as a calorie nutrition to provide the patient with carbohydrates for the correction of hypernatremia in hypoglycemia, and as a carrier solution for infusion of drugs and in the early postoperative period. The contraindication is in cerebral edema and severe hypokalemia. This is because dextrose can cause can stimulate the insulin secretion, which can cause the transcellular shift of potassium. Hence, it should be avoided in conditions of like severe hypokalemia. Next is dextrose saline solution, which is a hypertonic crystalloid. It contains dextrose 5 grams, which provides energy of 170 kilocalories, and it has 154 milliequivalents of sodium and chloride. The osmolarity is 560 milliosmoles per liter. The normal saline element corrects any ECF deficit of electrolytes, and dextrose element provides energy. It is also distributed mainly in the ECF compartment, but too much load can lead to hyperglycemia and osmotic diuresis. It is also preferred in hypochloremic metabolic alkalosis like normal saline. Next is hypertonic saline. So 3% and 5% hypertonic saline are FDA approved for traumatic brain injury, and the indications are in case of intracranial hypertension, severe hyponatremia, and hepatic encephalopathy. We have to cautiously given conditions which can cause fluid overload, like as in congestive cardiac failure. So coming to multi-electrolyte solutions, the common examples are isolite G, isolite M, and isolite P in dextrose 5% solution. So isolite G is used to replace the gastric juice in the treatment of metabolic alkalosis because of the presence of ammonium chloride. And isolite M, it is used as a maintenance fluid with 5% dextrose. It has the richest source of potassium of about 35 milliequivalents per liter. Hence, it is valuable in the treatment of hypokalemia. So that finishes off with crystalloids. Moving on to colloids. First is albumin, which is a natural colloid. So two preparations are available, that is 5% albumin and 20% albumin. 5% is iso-oncotic, and it is commonly used as a volume expander in hypovolemia. 100 ml 5% albumin increases the plasma volume by 100 ml, whereas 20% albumin is hyper-oncotic, and it is used in case of severe hypoalbuminemia and sepsis. 100% of this solution can increase the plasma volume by 500 ml. And effect of an infused albumin persists for at least 12 to 24 hours in the intravascular compartment. Another indications are in case of large volume paracentesis, in spontaneous bacterial peritonitis, in ovarian hyperstimulation syndrome, and 5% albumin, the dose is 10 to 20 ml per kg with an infusion rate of 1 to 2 ml per minute. And 20% albumin, the dose is 2 to 5 ml per kg with an infusion rate of 1 ml per minute. One good advantage of albumin is that the adverse effects are very rare, including the anaphylactic reactions. It also has reduced risk of hemostatic complications. Hence, albumin is a very effective volume expander, but too expensive. Hence, it has to be used selectively. Coming to the second colloid, that are dextrans. It is a semi-synthetic isotonic colloid. They are branched polymers of glucose molecule. Two preparations are available. That is dextran 40 as 10% solution and dextran 70 as 6% solution. Dextran 40 causes greater volume expansion, but the duration of action is short because of rapid renal excretion. So they are used in fluid resuscitation, and previously it was used for the prevention of venous thrombosis in post-surgical patients and to improve micro circulation in patients with gangrene. The dose should not exceed 20 ml per kg in first 24 hours, and it reduces the blood viscosity and improves micro circulation because of the antithrombotic effect. The antithrombotic effect can be dangerous also because it may increase the blood loss. It can cause severe anaphylactic reactions, impaired renal function, and interferes with the cross-matching. Hence, currently dextrans are not favored. Coming to the third colloid, that is hydroxyethyl starch. They are semi-synthetic colloids. They are derivatives of amylopectins. So starches are usually identified by the following terms. First is concentration. So two concentrations are available, 6% and 10% HES. So higher the concentration, higher is the initial volume expansion. Then comes the mean molecular weight. So starches with higher molecular weight are metabolized very slowly, so the duration of action is longer. Coming to the molar substitution, the starches can get easily hydrolyzed by the enzyme amylase. Hence, the original glucose molecules are replaced with the hydroxyethyl group at C2 and C6 position. So as per the molar substitution, three types of hydroxyethyl starches are available. That is hetastarch, pentastarch, and tetrastarch. So higher the degree of molar substitution, greater is the resistance to degradation by enzyme amylase and longer the intravascular persistence. C2 over C6 ratio is a substitution pattern. Higher the ratio, they are more slowly degraded and have longer half-life. So this is the typical representation, that is 6% HES, 130 bar 0.4 bar 9:1. Here 6% is the concentration, 130 is the molecular weight, 0.4 is the molar substitution, that is tetrastarch form, and 9:1 is the substitution pattern. So two types of two variants are available. So if the carrier solution is 0.9% normal saline, then it is called Voluven, and if the carrier solution is a balanced salt solution, then that is called Volulite. It has starches have low cost. There is no interference with blood drooping. Adverse effects like coagulopathy and anaphylactic reactions are extremely rare, and it can elevate the serum amylase level. One important factor is in critically ill and septic patients, it can cause acute kidney injury. Contraindications are non-hypersensitivity to HES, bleeding disorders, congestive heart failure, and renal failure. Coming to the last colloid, that are gelatins. They are semi-synthetic colloids which are isotonic. They are formed from the hydrolysis of collagen in the animal connective tissue. They are metabolized and excreted very rapidly. Hence, the effects last only for 1 to 2 hours. 3 commercially available gelatins are succinylated gelatins, example is gelofuscin, urea cross-linked gelatins, and oxypoly gelatins. They are used for the replacement for intravascular volume. They are the cheapest of all the colloids and more easily available. There is no infection risk if storage is proper. They are readily excreted through urine. Hence, there is less chance for developing acute kidney injury. They have a long shelf life and there is no need for refrigeration. It does not interfere with blood cross matching. And it has the highest risk of all. It can produce anaphylactic reactions, and gelatins have the highest risk of all the colloids. And the presentation can be delayed sometimes, that is after 15 minutes of infusion of gelatin. So that finishes off with colloids, and these are some of the studies that are conducted to know the efficacy of crystalloids and colloids in fluid resuscitation. So the name trial, like the crystal randomized trial in 2013, the Cochrane database review 2013 and 18, and the surviving sepsis campaign guidelines 2021 concluded that colloids are potent but not safe or preferred over crystalloids in fluid resuscitation. So summarizing crystalloids and colloids. So the recent literature suggests the use of 0.45% saline in 5% dextrose with addition of 20 milliequivalents per liter of potassium chloride as maintenance fluid. Normal saline and balanced salt solution are the first line therapy solutions in fluid resuscitation. 5% dextrose should be avoided in treatment of hypovolemic shock due to poor expansion of the intravascular volume and increased urine output due to osmotic diuresis. Colloids are always the second-line therapy agents in fluid resuscitation. Albumin is safe, potent, but very expensive, hence it has to be used selectively. HES is harmful, so better to avoid it. And in case if we are using, we have to use that in the initial phases of fluid resuscitation with a dose less than 30 ml per kg, duration not more than 24 hours. And we have to make sure that the patient should be followed up for the next 90 days for any worsening of kidney function. And out of the different variants available, the volulite variant is the safest among all the hydroxyethyl starches available. Dextrans and gelatins are not recommended. So earlier days, dextrans were frequently used in vascular surgeries because of their improvement in microcirculation. But because of the adverse effects, now it is not recommended. And the surviving sepsis campaign guidelines 2021 advised against the use of gelatin for acute resuscitation because of the side effects which outweighs the potential benefit. So large volume resuscitation can cause an acute hemodynamic overload. Especially it can cause serious impact in renal, cardiac, and hepatic diseases. Also, it can lead to hypothermia, dilution coagulopathy, and electrolyte imbalances. Specific adverse effects specific to crystalloids and colloids have been already explained before. And regarding the choice of fluid, the physician must choose the best available agent for each patient depending on the clinical condition and situation. There is no single IV fluid agent that meets all the criteria of an ideal fluid. So ideal fluid should remain within the intravascular space for many hours. The chemical composition should be similar to that of ECF. The constituents must be readily metabolized and excreted. It must be safe, sterile, and not prone to cause allergic reactions. And it should be easy to transport, store, and administer. Unfortunately, no such fluid exists. So this table shows some of the clinical situation and the best fluid of choice. So in case of sepsis and trauma, plasmalite and ringer lactate are the most commonly preferred fluids. In case of vomiting, which can cause to hypochloremic metabolic alkalosis, 0.9% sodium chloride is the preferred fluid. In hemorrhagic shock, balanced salt solutions and blood products are preferred. In diabetic ketoacidosis, 0.9% normal saline, plasmalates, and even ringer lactate are recent guidelines suggest the use of ringer lactate. And in case of major surgery, balanced crystalloids are the preferred fluid of choice. So the take-home message is that normal saline is physiologically abnormal. So if given a choice, always use ringer lactate. The volume infused matters more than the choice of the fluid. The choice of replacement fluid depends on the type of the fluid that has been lost. The preservation of glycocalyx is very important. So the physiology of glycocalyx has been already explained in the previous session. So studies have found that balanced salt solutions, albumin, and slow controlled infusion of solution helps in preserving glycocalyx, whereas the 0.9% normal saline, the synthetic colloids, and excessive and fast fluid administration can damage glycocalyx. Strong ion difference can help in guiding the selection of fluids in scenarios like acidosis and alkalosis. And the last, not the least, fluid choice and therapy should be individualized. So these are my references. Thank you, everyone.
Thank you, Anjali, for a detailed presentation regarding the various types of fluids. And some of the questions are there. And we will move on to the next session, that is by perioperative management of the fluid therapy by Dr. Asitha. Okay?
Yes, madam.
Okay, ma'am.
Okay. Share the slides, please.
Is it visible, ma'am?
No, the slides are not visible. You can press on to the share button so that it will be. Yes. Now you can share it. Not seen. Yes. Okay. Yeah. Okay, now it's visible. Okay, Asitha, you can start with it.
Good evening, all. Now moving on to perioperative fluid therapy in adults. I am briefing the topic under the following headings: Introduction, causes and effects of the fluid imbalance, fluid responsiveness and assessment, different types of fluid therapy, goal-directed fluid therapy in detail, and fluid management in special conditions. Perioperative fluid management is a key component in the care of the surgical patient, impact outcomes, and plays a pivotal role in enhanced recovery pathways. Improving fluid management during perioperative period leads to decrease in complications, length of hospital stay, and enhanced patient outcomes. Causes of perioperative fluid imbalance. These include preoperative factors, intraoperative factors, and postoperative factors. Then preoperative factors include prolonged starvation may resulting in severe fluid deficit that can cause hypovolemia. So better to avoid cessation, clear fluids, advise clear fluids 2 hours prior to surgery, and can give complex carbohydrate drinks such as maltodextrins 45 grams 2 hours prior to surgery. What is the purpose of giving a complex carbohydrate prior to surgery? Because of the prolonged starvation, the metabolism will be in a catabolic state. By giving maltodextrins, we can improve the metabolism into anabolic state. That can decrease the insulin resistance, reduce the post-op nausea, vomiting, and anxiety of the patient can be reduced to a limited extent. Then excessive bowel preparation can cause weight loss up to 1.5 to 1.7 kg with high water and potassium loss. So we have to replace it with simultaneous administration of 1 to 2 liters of crystalloids with potassium supplementation.
And there may be direct intravascular depletion from the bleeding, GI loss due to vomiting or diarrhea, fluid sequestration in third space with edema, pleural effusion, and ascites. All this can cause preoperative hypovolemia. In emergency surgery, patient may have acute disturbances in the fluid compartment. This requires timely resuscitation guided by NIBP, heart rate, serum lactate, urine output, and mixed or central venous saturation. A pragmatic approach is required to provide ongoing fluid resuscitation without compromising surgical intervention. Then coming to the intraoperative factors, these include anesthesia-related factors and surgical factors. The anesthesia-related factors include most of the general anesthesia-inducing drugs can cause a dose-dependent vasodilatation and myocardial suppression. This can cause intraoperative hypotension. Central neuraxin blockade can cause sympatholysis and hence induce hypotension. Then surgery-related factors include excessive hemorrhage from the surgical site, coagulopathy due to hemodilution or hypothermia, prolonged operating time, and positive pressure ventilation with high tidal volume, recruitment maneuvers, and PEEP that can increase the intrathoracic pressure that decreases the venous return and cardiac output. Hence, intraoperative hypotension occurs. And during laparoscopy, pneumoperitoneum is created that can cause decreased venous return and decrease in cardiac output. Then what are the postoperative factors? Surgery itself can cause tissue trauma, hence triggers inflammation and immune response. If there is an hypotension occurs, all the vital organs are perfused by autoregulation, but the GI tract is hypoperfused. That can lead to mucosal ischemia and microbial invasion that can cause a systemic inflammatory response syndrome. This can disrupt the endothelial glycocalyx integrity. This will cause fluid imbalance. Excessive IV fluid administration can lead to release of cardiac natriuretic peptides, which further degrade this endothelial glycocalyx. Postoperative stress response also turns the metabolism to catabolic state. ADH release that can cause postoperative retention of water and oliguria. Here, the oliguria is due to ADH release, but the patient may have a normal circulating volume. Accumulation of fluid from the circulating volume into third space or sequestration in the bowel lumen or removal through vomiting, nasogastric tube, nasogastric drainage or stoma loss all can cause postoperative hypovolemia. Then what are the effects of fluid imbalance? Hypovolemia may cause insufficient circulation to the tissues, decreased oxygen delivery, shock, and multi-organ dysfunction. Then what are the effects of hypervolemia? The volume overload may cause respiratory effects like pulmonary edema, ventilation perfusion mismatch, and respiratory failure, sometimes pneumonia. And gastrointestinal effects include gastrointestinal edema, anastomotic leak, and paralytic ileus. There may be delayed wound healing and infection, and it can cause effects on hemostasis due to dilution of the coagulation factors that can result in coagulopathy. All this can increase the length of stay in hospital and morbidity of the patient. So, what are the goals of perioperative fluid management? We have to maintain or correct the fluid balance by correcting dehydration or hypovolemia, maintain or correct the plasma constitution by correction of electrolytes, to secure sufficient circulation in combination with vasoactive or cardiac substances, to secure sufficient oxygen delivery to organs in combination with oxygen therapy. Before going to fluid therapy, we have to know what is fluid responsiveness. It is also known as volume responsiveness or preload responsiveness. This is the increase in stroke volume or cardiac output by more than 10 to 15% after a patient receives a fluid challenge. Then what is a fluid challenge? We are giving a 200 to 250 ml of crystalloid fluid over 5 minutes to look for an increase in stroke volume or cardiac output. We are using various parameters to assess the fluid responsiveness that include static parameters and dynamic parameters. Static parameters include blood pressure, heart rate, pulse oximetry, urine output, central venous pressure, pulmonary artery occlusion pressure, right atrial pressure. These parameters will only assess the current preload status of the patient. They does not identify the volume deficit, do not correlate with the cardiac output. So it may lead to over or under transfusion. Here comes the importance of dynamic monitors. The criteria is that patient should be in mechanical ventilation with tidal volume more than 8 ml per kg, and patient should be in normal sinus rhythm. Here we are looking for the variation in variation of stroke volume and pulse pressure according to the respiratory pattern. Here the stroke volume variation and pulse pressure variation more than 10%, then the patient is said to be fluid responsive. Then we can use the transesophageal echo to assess left ventricular end diastolic volume. Esophageal Doppler can be used to assess the blood flow velocity in the descending thoracic aorta to estimate the stroke volume. Then IVC collapsibility index. Normally it collapses during inspiration and distend during expiration. So the IVC collapsibility index is calculated by the maximum diameter minus minimum diameter divided by maximum diameter into 100. It is normally 20 to 50%. If it is less than 20%, that means patient is fluid responsive. Then we can do a passive leg raise test. Here the patient have to be seated, placed in semi-recumbent position with 45-degree up. After that, we will keep the patient head in neutral position and keep the lower limb in 45-degree up. This acts as a fluid challenge that may increase the venous return and increase the cardiac output. So there will be an increase in stroke volume by stroke volume. If it is more than 10%, that means that patient is fluid responsive. The another test is an expiratory occlusion test. Here, patient with mechanical ventilation, we have to occlude the expiratory tubing for a 30 to 60 seconds to prevent the next inspiration to happen. This may increase the preload, so stroke volume will increase. If stroke volume is increased more than 10%, then it's said to be fluid responsive. Then measurement of the serum lactate level is an important indicator of global tissue perfusion. Normally it is less than 2 millimole per liter. If it is more than 4 millimole per liter, we need immediate intervention in critically ill patients. Then which fluid we have to choose? Crystalloid, colloid or blood? Crystalloids and colloids are discussed in detail by Dr. Anjali. Crystalloids are crystalloid solution, ringer lactate is the most widely used fluid, but balanced salt solutions are mainly used to maintain the normovolemia or to replace the lost blood. During resuscitation, the crystalloids are administered in 1.5:1 volume basis for the blood loss. Colloids, no evidence that colloid solutions are superior to balanced salt solution. During blood loss, the colloids are administered on 1:1 basis until a transfusion threshold is met. Blood, we will give blood only when there will be an exaggerated blood loss with a transfusion threshold is met. It is 7 gram per deciliter for a healthy patient. And patient with ischemic heart disease, we can give transfusion when the HB value drops less than 9 gram per deciliter. We can give plasma derivatives to replace labile coagulation factors during massive transfusion, acute DIC in presence of bleeding or abnormal coagulation. Then coming to different strategies of fluid therapy, we have traditional fluid therapy, liberal fluid therapy, restrictive or zero balance fluid therapy, goal-directed fluid therapy. This is the intraoperative fluid approach to different patient for different surgery. For low-risk patient coming for minor surgery, we will prefer liberal fluid therapy. But for the moderate risk and high-risk patient for major or intermediate surgery, we will prefer restricted or goal-directed fluid therapy. Then traditional fluid therapy, here the fluid replacement is divided into correction of the deficit fluid due to fasting and other deficits. We have to correct the deficit fluid within the first 3 hours. Then we will give maintenance fluid hourly. Then correction of third place losses and replacement of the intraoperative blood loss and other losses with blood and blood products. Liberal strategy, there are some myths concerned with it. We will infuse large volume of crystalloid, more than 4 liters. The concept is assumed that surgical patients are hypovolemic due to prolonged fasting. The wide misconception is that surgical exposure may require aggressive replacement of nebulous insensible fluid loss, often termed third space loss. But the fact is that preoperative dehydration is eliminated by reduced fasting time and use of fluid up to 2 hours before operation. Patient without significant cardiopulmonary disease, the blood volume is normal even after prolonged fasting. The preoperative fasting did not alter the dynamic and static preload indices in patients with ASA 1 to 3. The concept of third space is completely eliminated. The Chappell et al. 2008 titled A Rational Approach to Perioperative Fluid Management criticizes the traditional liberal fluid therapy and role of endothelial glycocalyx in fluid therapy. Shin et al. 2018 titled The Effects of Intraoperative Fluid Management on Postoperative Outcome describe about the complications of liberal fluid therapy and importance of goal-directed fluid therapy. Then coming to restrictive fluid management. This is mainly used for major surgery with blood loss less than 500 ml. Here a restrictive zero balance strategy is used. No preloading of fluid, replacement of blood loss with colloid in 1:1 basis and with crystalloid 1.5:1 basis. No replacement of intraoperative, interstitial or third space loss or urine output. Administration of vasopressors for correcting intraoperative hypotension. And less intraoperative blood loss and need for blood transfusion in such patients. But the risk is that they are more prone for acute kidney injury. A systematic review and meta-analysis of Asitha in major abdominal surgery by Messina et al. In 2021, they conducted a study, 3,000 patients undergoing major abdominal surgery. In restrictive group, they received more than up to 3.7 liters. They have a rate of acute kidney injury 8.6%. Whereas in liberal group, it is about 5%. So the acute kidney injury incidence is more in the restrictive group than liberal group. So we are currently following the goal-directed fluid therapy for all major invasive surgery with massive fluid shift. The gold standard for perioperative fluid management in critical illness during major surgery with significant fluid shift and blood loss. Here the fluid therapy concept of individualized goal-directed cardiovascular optimization and assessment on a procedure-specific basis. Goal-directed therapy utilizes monitoring technique to help clinicians with administering fluids, vasopressors, inotropes, or other treatments. The main aim is individuals' intravascular volume optimization to get maximum cardiac stroke volume. So indications are intermediate or high-risk patients with invasive, complex, or high-risk major surgery with major fluid shift and significant blood loss. Goals are optimizing the fluid balance, provide individualized fluid management, prevent complication, and enhance patient recovery. These are the 5 T's of goal-directed fluid therapy. That we have to identify the target population and categorize the risk of the patient, whether it is low, medium, or high risk patient, whether it is minor risk or intermediate risk or high risk surgery. And the intervention should start in the pre-op period itself, and it should be continued in the post-operative period also. And the type of intervention should be IV fluid combined with inotropes and vasopressors. And our target should be static and dynamic variables such as heart rate, mean arterial BP, CVP, pulmonary artery occlusion pressure, stroke volume variation, pulse pressure variation, cardiac index, and stroke volume. And the target should be personalized. This is an algorithm of intraoperative goal-directed therapy. Here the patient is in positive pressure ventilation with tidal volume 8 ml per kg and PEEP 4 millimeters of mercury, and patient is in normal sinus rhythm. We will give a maintenance fluid crystalloid, preferably balanced salt solution for 4 ml per kg per hour. Monitor and record stroke volume variation and cardiac index. If the stroke volume variation is more than 12% for 5 minutes, that means the patient is fluid responsive. We will give a fluid challenge of 250 ml crystalloid and look for the variation in the stroke volume. If the stroke volume is less than 12%, that means patient is not fluid responsive. But the patient is responsive, we can give the fluid challenge. Along with this, we can look for the cardiac index. If it is more than 2.5 liter per minute per meter square and mean arterial BP is more than 65 millimeters of mercury, we can reevaluate the patient after 5 minutes. And but the cardiac index is less than 2.5 liter per minute per meter square, with this fluid challenge, we can start inotropes. And even with that, if the BP is less than, mean arterial BP is less than 65 millimeters of mercury, we can add vasopressors. This is the nutshell of goal-directed therapy in enhanced recovery. In the preoperative period, we have to minimize the NPO, and we can give complex carbohydrate drink 2 hours prior to surgery. Bowel preparation should be restricted, and replacement with isoosmotic agents, and classify the patient's risk stratification based on the available and validated surgical risk calculators. And intraoperatively, for the low-risk patient, we use standard monitoring and give maintenance fluid at a rate of 1 to 4 ml per kg per hour while avoiding large deviation from zero balance. For the medium and high-risk patient, we follow the goal-directed fluid therapy. We will use the dynamic parameters. According to the parameter, we will assess the fluid responsiveness and give fluid accordingly. If the patient is not fluid response, we will add inotropes and vasopressors and reverse the problem. And the immediate postoperative period, that is in the 0 to 12 hour, the IV fluid should be infused at a rate of 1 ml per kg per hour. And as soon as possible, we start to give oral fluid, oral intake. If the patient is not tolerating oral, we can continue the IV fluids, especially in medium and high risk patients. In the late postoperative period, we can continue the oral feeds and provide adequate analgesia, early ambulation, and adequate sleep. So this will improve the enhanced recovery, decreases the hospital stay and outcome in the patient. What are the limitations of goal-directed therapy? High cost, unavailability, lack of knowledge among the clinicians because of the invasiveness and complexity of the techniques. Then about the special consideration, heart failure. In heart failure, there will be systolic and diastolic dysfunction, activation of the renin-angiotensin axis with salt and water retention, and sympathetic overactivity. And the drugs used are diuretics that can cause volume contraction and electrolyte imbalance. AC inhibitors and ARBs can cause refractory hypotension. So hypotension induced by these drugs should be treated with small doses of inotropic or vasopressor with judicious volume correction. Goal should be preserve cardiac output, prevent both forward and backward heart failure, optimizing the preload and afterload and contractility. Minimize cardiac workload by avoiding oxygen demand supply mismatch. Monitoring with transesophageal echo is mandatory. In chronic kidney disease, the decreased urine output itself can cause volume overload. There may be impaired oxygen delivery due to chronic anemia, endothelial dysfunction, microvascular perfusion abnormalities. There may be coexistence of heart failure and systemic or pulmonary hypertension. And bleeding risk is there because of the platelet dysfunction. So, preoperative hemodialysis is essential to optimize the normal blood volume and achieve dry weight prior to surgery. Always check electrolytes, especially potassium, on morning of surgery after hemodialysis. Monitoring with invasive CVP, IBP, and cardiac output. Large volumes of isotonic saline should be avoided because it can induce acidosis that favors extrusion of potassium from the cell. Alternative crystalloid is a potassium-free bicarbonate buffered dialysis solution such as Hemosol. Colloids which aggravate pre-existing renal dysfunction should be avoided. Human leukocyte antigen matched blood may required to minimize the antibody formation and future difficulty with blood and tissue matching for those who are awaiting for the renal transplantation. Upper GI losses, congenital or acquired gastric outlet obstruction can resulting in dehydration, hypokalemia, and alkalosis caused by proton loss with raised serum bicarbonate. And there will be increased aldosterone secretion that causes sodium and water retention, resulting in hypokalemia and worsening of metabolic alkalosis with a paradoxical acid in urine. The alkalosis also reduces the circulating ionized fraction of calcium. So correction should be gradual, rehydration with isotonic saline and potassium supplementation. Changing to dextrose containing solution depends on the electrolyte analysis. And surgery to correct the gastric outlet obstruction should be done only after correction of volume and acid-base status. Then sepsis and acute lung injury. Here the concerns are cardiovascular instability due to endothelial dysfunction and intravascular fluid loss, vasodilatation with fluid maldistribution, sympathetic redistribution of blood away from the peripheral circulation, and impairment of the cardiac function. Fluid resuscitation with goal of maintaining adequate end-organ perfusion is the key part of the first 6 hours of sepsis treatment according to the Surviving Sepsis campaign. At least 30 ml per kg of crystalloid should be given within first 3 hours of resuscitation, and the further fluid should be guided by frequent reassessment of the hemodynamic status using cardiac output, heart rate, BP, and urine output. Dynamic test of fluid responsiveness such as passive leg rise or stroke volume responsive fluid challenge are recommended over static targets such as fixed CVP value. Other resuscitation targets include MAP more than 65 millimeters in those requiring vasopressin and normalization of lactate in patients with elevated levels. This is the goal-directed therapy in critically ill patients. Assess the hemodynamic stability of the patient. If the patient is unstable, we have to resuscitate the patient. Assess and treat the cause of instability. Obtain minimum acceptable BP. That is, in adult, it is around 60 to mean arterial BP is around 60 to 65 millimeters of mercury. Give isotonic crystalloid 0.5 liter aliquots. Consider 4 to 5% albumin for sepsis if patient remain unstable. Can give RBCs, blood products, and tranexamic acid if patient having active bleeding. And start inotrope or vasopressor support. Consider damage control surgery if indicated. After this resuscitation stage, next is the optimization stage. Improve organ perfusion. Assess the improved organ perfusion, peripheral color and temperature, and mentation of the patient. And MAP should be more than 65 millimeters of mercury. Cardiac index should be more than 2.2 liter per minute per meter square. Urine output more than 0.5 ml per kg per hour. Normal serum lactate should be less than 2 millimole per liter. Further, isotonic crystalloid used if needed. Continue inotrope and vasopressor support. Next is the stabilization phase. Adopt a restrictive approach in the stabilization phase. Organ support is given if needed. Start enteral feeds as early as possible and adopt a restrictive approach to the oxygen also. Then coming to the de-escalation phase, here maintain the parameters achieved during stabilization while reducing the support. Normalize according to the patient's age and condition. And we start the oral fluids and oral drugs. Obtain a negative fluid balance via spontaneous or diuretic-induced diuresis or ultrafiltration. Reduce the intensity of organ support. Continue enteral feeding. This is the goal-directed therapy in critically ill patients. Then in burns, severe endothelial dysfunction and fluid maldistribution, ischemia and reperfusion injuries can cause severe inflammatory response syndrome. IV fluid therapy is indicated for burns more than 15% of total body surface area in adults and more than 10% of total body surface area in children. Initially, fluid management was based on Parkland formula with urine output more than 0.5 to 1 ml per kg per hour, but the adverse effect of volume overload that can lead to pulmonary edema, increased intraocular pressure, and intra-abdominal hypertension. Now using HIFO formula using lower volumes to target stroke volume. Intra-abdominal pressure should be monitored and checked for resuscitation endpoints such as lactates, cardiac output, in addition to urine output. Then coming to hepatic failure, here the pathophysiology include peripheral vasodilatation and intravascular depletion, destruction of the liver architecture with decreased nitric oxide bioavailability, lead to increased vasoconstriction production and sinusoidal hypertension. There will be splanchnic and systemic vasodilatation that trigger RAS and sympathetic nervous system activation, decreased lymphatic drainage, and neurohumoral response lead to renoconstriction and hepatorenal syndrome. So, treatment strategy should be dietary fluid and salt restriction, use of diuretics, intermittent or continuous drainage of ascites, and fluid administration should be goal-directed with cardiac output monitoring, and always give isotonic crystalloids, colloid, or blood. Then, in obstetrics, the fluid management is significant in preeclampsia because there is decreased plasma volume, endothelial dysfunction, and hypoalbuminemia. Acute pulmonary edema is the leading cause of death in severe preeclampsia. So always follow a restricted volume management with IV balanced salt solution, usually 80 ml per hour, including that received as drug diluents. Invasive monitoring is indicated in severe preeclampsia. So the take-home message is that normovolemia should be maintained throughout perioperative period to maintain adequate organ perfusion. Avoid prolonged fasting and give carbohydrate drink 2 hours prior to surgery. Dynamic monitors that guide goal-directed therapy in patient undergoing major invasive surgery with large fluid shift or blood loss. Give IV fluids only to those who are fluid responsive. Start vasopressors and inotropes if needed to provide adequate tissue perfusion. Start oral fluids as early as possible in the postoperative period. Stop fluids when they are no longer needed and the patient can have oral fluids. These are my references. Thank you. Thank you, Ashita, for a detailed and excellent presentation regarding the perioperative management of the fluids. Sir, shall we I think that there are some questions are there in the chat box.
You have to take
Shall
it.
If you can also take it, sir.
Yes. I have seen
Okay, sir.
couple
Okay.
of questions, but you
Yeah.
ask the speakers or else we will top it up.
Okay, they will say.
So the first question is Dr. Muthukumar Rajagopalan has asked what intravenous fluid is to be used in renal failure.
Anjali?
Yes, ma'am. Sir, the ideal fluids will be to use balanced salt solutions. I think because they do not, they have less risk of developing hyperchloremia related metabolic acidosis and renal injury. The preferred solutions will be balanced salt solution in renal failure patients.
So you have to select a fluid which contains less of potassium or no potassium. Same way, the fluid should not develop acidosis like your normal saline. So as you said, it is balanced salt solution. Accepted. Then he has asked a very relevant question. Because you have repeatedly mentioned that normal saline is physiologically abnormal. So he's asking, when it is physiologically abnormal, why it is called normal saline?
Sir, actually, it is a historical artifact because during the earlier days, when they were assessing the concentrations of different fluids, so this was the only fluid at that time which did not cause any cell lysis. So that time they thought this 0.9% normal saline is the only solution that is isotonic with the blood plasma. So that is why that name, normal saline. It is because of the history actually, nothing relevant.
Yeah,
We are saying it as normal saline, sir.
that is an intelligent answer because it is like that only. It is a common thing because that was the first fluid to be devised, and they thought sodium and chloride, everything will resolve all the problem, like your ECF. So they have named. So in a nutshell, what I want to convey in any progress of science, initially which is normal, at a later date it may be abnormal. That is what happened with the dextran hydroxyethyl starch. I have used right and left. When you talked about substitution of these molar places, see, HES I used to right and left except in renal failure. But now see, it is totally out. People used this degraded polymer gelatin under the name Hemexel. Now it is not seen by, it would not have been seen by Dr. Vinduja. But every time we used to say, so whatever abnormal today, it may be abnormal tomorrow. So now we are professors, we are teaching, we may be abnormal when Dr. Vinduja becomes the professor. It is the life cycle is like that. So again, he has asked another question. What is the ideal fluid for neural patients with high ICP?
Okay. So among, if you're asking if we have to choose between normal saline and ringer lactate, it will be normal saline. This is because ringer lactate is actually little bit hypotonic. That is with an osmolarity of 273 milliosmoles per liter. Hence, hypotonic solutions can worsen the cerebral edema. Hence, in neuro patients, if we are asking if it is between normal saline and ringer lactate, normal saline will be the preferred one over ringer lactate.
But
Because
actually, we are going to use hypertonic saline even to
yeah,
treat
yeah,
ICP.
yes,
We
sir,
are
yes,
going
sir.
to treat ICP. So
Yes,
we
sir.
need diuresis actually. That is the reason we are using mannitol. So which
Yes,
is the
sir.
ideal fluid? Restrict the fluid. Promote
Zero
diuresis.
balance,
Diuresis.
zero balance
Zero balance.
saline.
Yeah,
That is
nowadays
the,
actually
yeah.
hypertonic saline is preferred over mannitol because of this hemodynamic
Yeah, that
stability
is right.
issues. Yes.
What I want to convey, basically, you have to reduce the IV fluid
Cerebral
because
edema.
India is like that. So it is actually a fantastic show. We have taken a screenshot also. Anything madam wants to convey, madam can convey as a concluding remarks because
Sir,
all
I think,
questions are answered.
sir, I think the fluids we have covered almost in all parts of the fluids, that is from the physiology to the advanced management of all these physiological conditions that we usually face. So I think they have conveyed all the relevant points that are required for the PG students as well as also the practicing anesthesiologists.
It is really good. It is really good. We are also happy as organizers of the event. We are very happy to see the faculties demonstrating their skill and caliber. Now I request Dr. Hema, our treasurer, to propose the formal vote of thanks.
Thank you, sir. Good evening, everyone. I thank you all for participating in today's episode on the intravenous fluid therapy. Our sincere gratitude to our academic chairman, Dr. A.L.M. sir, the man behind the Puthukkottai webinar series. I thank the Department of Anesthesiology, MES Medical College, Perinthalmanna, Kerala, for your well-structured, detailed, and easy to understand presentation today. I thank our moderator, Dr. Shamsad Begum, Professor HOD, MES Medical College, Perinthalmanna Medical College. Thank you, ma'am. I thank Dr. Vinduja Suresh. I thank Dr. Anjali Rajan. Thank you, Dr. Asmitha. Thank you for your presentation, ma'am. I thank all the participants, colleagues, and postgraduates. And we expect the same enthusiasm in our upcoming episode workshop and CE program on 14th and 15th of June 2025. Thank you. Thank you all.
So thanks, Dr. Hema. See, you find it difficult to pronounce Perinthalmanna, but that Perinthalmanna I have visited thrice. So it comes under Malappuram district, which I know. So the same way, this Perinthalmanna anesthesiologists now know what is Puthukkottai and what is a Wednesday. So it is a Bhudhan. So that Budhwar, Wednesday, everyone knows. See, that is the idea of exchange. Now, Puthukkottai people will pronounce Perinthalmanna and they will remember MES by their heart. So I thank one and all. And the next webinar will be on cardiac ionotropes. It is ionotropic support we have decided. So the postgraduate will be from Pondicherry. But what I want to convey, the faculties are extremely intelligent faculty of international standard because Dr. P.S.N. Raju, Chief Cardiac Anesthetist from Apollo Hospitals, Vanagaram, he is going to deliver a lecture on pharmacological inotropic support. And Dr. Subandhu Sakkar from Kolkata, he is going to talk about mechanical support of the heart. And it will be moderated by Dr. Muralidhar Kanchi from Narayan Hridalaya. She is even an instructor to Boston and all. So next time we will come with more power because it is inotropy. Now you have given preload. As a matter of fluid, we have given preload. Then we will check inotrop in the next week. Now I request the ClearNet to pass their concluding remarks and to wind up the session.
Thank you so much, everyone, for this wonderful session. ClearNet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session over here.
Thank you. That postgraduate is Balaji Sendil from Mahatma Gandhi Medical College, Puthukkottai, because the youngest faculty we have to mention. These are, he is going to talk with the senior most faculty. Thank you.
Okay, thanks a lot, sir.
Thank you, madam.
Thank you, sir.
Thank
Thank you, madam.
Thank you, sir.
Thank you, ma'am.
Thank you, sir.